Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
So I'm going to start our panel off with a question that I think our community peers are answering sometimes differently than we are, but the relative use of tissue and liquid biopsies. So I'll start with you, Dr. Thompson, because you're the pulmonologist here, right? Dr. Dagogo-Jack and I don't diagnose lung cancer that often. At least I'll say I don't. I'm guessing you don't either. So you have a newly diagnosed lung cancer patient. When are you ordering a liquid test, and when are you ordering a tissue-based test?
Yeah, I think it becomes, like a real challenge, as I mentioned, that, it's very frequently that we encounter, insufficient tissue because, like in lung cancer, it can be difficult to access some of the tumors. And then our biopsy instruments are very small, and biomarker demands have increased on the tumor tissue. And so I think, traditionally, like those who have, access to, tissue sequencing platforms, I think, most, like proceduralists or medical oncologists will initially order, tissue sequencing, by default. And then we'll also additionally order a liquid biopsy, in cases where, the pathologist has noted that there might be limited tissue available, or that the tissue biopsy is actually, insufficient for molecular testing. I think, one critical point has been, in pathologists really commenting that, on the sufficiency of tumor tissue for downstream sequencing has been critical to identify, like how do you, time whether a patient might need a repeat biopsy or a liquid biopsy. And so I think liquid biopsies are often used if, like there's not sufficient tissue from the original biopsy, if there's, or the patient might be coming from a different institution where they were diagnosed, and it's unclear exactly when, what happened to the tissue, or if it's being sent for sequencing. And then sometimes if you expect long delays in the tissue sequencing result, you have a patient, in front of you, there's already, it's already been a long journey to get, to the medical oncologist, and they're ready to start treatment. And so liquid biopsies are often ordered in that circumstance, with that, 7 to 10 day turnaround, in hopes to, identify a specific mutation and get treatment started right away. So that's been what I've seen traditionally, how, tissue and liquid biopsies have been utilized.
So you mentioned turnaround. What's acceptable for turnaround?
Yeah, I think
I'd like to point that to Dr. Dagogo-Jack, because she's the consumer here, right?
Yeah.
Our patients and doctors are the consumers of molecular testing. Personally, I'm an impatient New Yorker by birth. I've been told many times since moving down to North Carolina to slow down, but I don't feel particularly patient. I know my patients don't either. Dr. Dagogo-Jack, as the person who's going to use this to advise patients, what's fast enough?
Yeah, I think that this gets to a very good question. So if you look at guidelines from a year or two ago, it used to say under 2 weeks is fast enough, but I think that you have highlighted the key points, right? 2 weeks is very long when you're trying to delay therapies. And so I think as fast as possible is fast enough. And that is that's one of the advantages of a liquid biopsy. In my mind, in an ideal scenario, we would be able to send both liquid and tissue at the beginning for everyone, and then and we've already seen that liquid biopsy is presented as a very kind of sensitive tool, a specific tool, basically. And so if you find something, you can act on it. And so I think that would be the ideal strategy. I will say, at least internally at our institution, they've developed different pathways depending on the likelihood of having an actionable alteration to speed up the testing using our local assay. So we can sometimes get it under a week for patients where we're really, really on the kind of waiting to start therapy and someone has a very symptomatic disease.
Yeah, so the pathologists have a term in their academic literature that I find overly polite. The term is they call it preanalytic variables. So preanalytic variables is anything that happens before the sample is ready to go onto a sequencer, right, to actually be tested. I call that nonsense, or when I'm not on a public forum, I use other explicatives for it. And the explicatives come from a passion, because this is delaying care. At my institution, it can take 2 weeks to get tissue in a FedEx envelope to get it tested. And I know I'm not alone. I may be alone in being willing to say this out loud, but that's actually fairly normal in the US. And so what that means is that if the testing then takes a few weeks, it can be 4 weeks or longer for traditional tissue testing to answer. Whereas liquid, there's no reason to not have an answer within a week if it gives you an answer. So I think it's a little different for folks at major academic places and our community partners where liquid is the most useful. Because in my practice, if at my tumor board, if I say who wants to biopsy this patient, it's like throwing filet mignon into the lion's den. My interventional pulmonologist, my surgeon, my vascular interventionologist are all, let's say, very anxious to help. My best friend is in community practice in the middle of nowhere, New Jersey, he has a little bit more trouble convincing his interventional partners to put sharp objects into patients, right? It can take an argument to get it done. So I think in the community, the lack of tissue is a big factor. They don't have access to people like Dr. Thompson, who are going to always get us lots of tissue. Whereas, I find speed to be my biggest driver for the use of liquid. But I'm going to turn the same question and recycle it for resistance testing. Dr. Thompson, you mentioned that liquid may now be the preferred test for resistance changes.
Yeah, and in fact, I think it's been, people have been hinting about whether to use what we call a plasma first approach, in patients progressing on targeted therapies. And just in early July, they published in the Journal of Thoracic Oncology a statement paper, advocating that in patients progressing on targeted therapies, that a liquid biopsy should be the first approach to assess for resistance mutations. And now with a number of different targeted therapies at disease progression, it's going to be important to identify various mechanisms of resistance. And as we mentioned numerous times, that the liquid biopsies are minimally invasive. They have rapid turnaround times. And so, probably in that circumstance, the best thing to do is that perform a liquid biopsy. And while you're performing, you can start to prepare the patient and set them up for an invasive tissue biopsy. But if that liquid biopsy comes back with a specific mechanism of resistance, then you've saved a lot of time. And you've kind of minimized, risk to the patient, because you've obviated the need for an invasive procedure. And so here I am as a proceduralist, advocating for liquid biopsy. But I think, liquid biopsies have really, changed, the landscape for our patients, really for the betterment. And so I think this was a great recommendation to use liquid biopsy as a first approach, and then reflex to tissue if the liquid biopsy is needed.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly and Exelexis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.